just recently come on the block. It's the first major advance in 40 years for the treatment of PDR. We can take an eye that looks like this with very active NVD, and with one injection, we can transform it into this picture with no active NVD. So we now have a choice of treatment, anti-VEGF or PRP, and that is the basis of this debate. Now, canned retinal coagulation is an excellent treatment. It's been around for a long time, but it destroys large swaths of retina. It causes peripheral visual field loss, night vision loss, and DME. And we know that it's not perfect. 5% will still suffer severe vision loss despite PRP. Look at this eye with very active NVD and macular traction. This is the same eye 2 days after a single injection, and you can see significant regression of the NVD. This is it at 4 months. The NVD is completely contracted and the macular traction is relieved. Try doing that with PRP. And this is the same eye 3 months after 6 injections and almost no diabetic retinopathy except the regressed NVD. If you don't believe that, you can look at this patient. High-risk PDR with a preretinal hemorrhage. The same eye after 1 injection with less hemorrhage, same eye after 3 injections. And this is the eye nearly 3 years after this with only 9 injections. And you could never really tell that this eye ever had diabetic retinopathy. What other advantages are there? Well, you can use anti-VEGF in miosis, cataracts, asteroid pylosis, and vitreous hemorrhage. And if you don't believe that, there was this landmark study, the Protocol S study by the DRCR Retina Network, comparing anti-VEGF to PRP. And it showed at 2 years that there was that anti-VEGF was not inferior to PRP, but it also showed superior vision over the course of 2 years. This is the visual benefit to the patient during the entire study period, not just at the end. There was less visual field loss and less operations. PRP, well, there were fewer visits, and of course there were less injections, only in those eyes that had DME. And then we carried this out to 5 years, and it showed that both groups ended up with excellent vision 20/25, but it also showed that the PRP group had a much higher incidence of DME and a much higher rate of retinal detachment. Now this topic, I know Dr. Elliott is going to bring this up, and of course I have to say this was Mark Johnson sitting right there in the front row, but we call this non-compliance or loss to follow-up, but it's not just anti-VEGF. PRP is not one and done. Over 50% require more PRP, such as this eye, that got PRP, developed a preretinal hemorrhage, lost to follow-up, and came back with vision loss. And this eye, young male with very active neovascularization after 2 PRPs, not much change, but you add a little bit of anti-VEGF and voila, it's almost all regressed. And when you look at 5 years, by the 5th year, almost 40% of eyes did not require an injection. And if you don't believe that, this medal was awarded for the best piece of original work for the Clarity study. First time in 10 years, and it showed that anti-VEGF was superior to PRP. So you can take an eye like this on the left with a preretinal hemorrhage and transform it into an eye like this with almost no retinopathy. Dr. Elliott, my patients want wide vistas of vision, not little tiny limited islands of sight. Audience vote pro.
Physician Dean Elliott will present his side.
We thank the DRCR investigators, especially Dr. Gross. However, I respectfully disagree on this topic. The ASRM PATH survey respondents overwhelmingly agree with my position, which is PRP monotherapy is preferred over injection monotherapy. The 2-year results of Protocol S showed some unique features of ranibizumab therapy, which is the risk of endophthalmitis, risk of systemic exposure, and greater expense. The 5-year results show that 33% are lost to follow-up. When comparing the 2 groups, there was no difference in visual acuity, no difference in vision-related quality of life. and the visual field progressed in both groups, which was an unanticipated finding in the ranibizumab group, such that the difference between the two groups diminished over time. The Clarity study looked at aflibercept against PRP, and there were no differences for vitrectomy, contrast sensitivity, or low luminance vision. An editorial on the Clarity showed that adherence to follow-up in the community may be low and could lead to blindness. A real-world study was conducted at Wills. They defined loss to follow-up as greater than 12 months until the return visit, which is not a very strict definition. Despite that, 25% were lost to follow-up. Comparing the two groups, injections did worse on a number of features, all statistically significant. A multi-center case series spearheaded by Mark Johnson showed that treatment interruption in eyes that had been receiving injections were due to illness, non-compliance, and financial issues. When patients returned, they had terrible anatomic outcomes and horrible vision, 46% had hand motion or worse. In patients who are managed with anti-VEGF therapy alone, the unintentional treatment interruptions result, there's that word again, blindness. The risk is equal to probability of an unfavorable outcome times consequences of that outcome. The probability of treatment interruption is substantial, and the consequences are dreadful. Cost shows that PRP is 85 to 90% lower than for injections. The treatment burden is excessive. So medicine is a science, but it is also an art, and every patient is different, and we don't know who is going to be non-compliant. So which would you prefer to do? Almost one-and-done therapy, or repeated injections followed by a period of non-compliance and subsequent rubiosis and blindness? And finally, PRP is highly durable, more cost-effective, and provides better outcomes when patients are lost to follow. Thank you.
Please follow the directions here. A for pro, B for con.
There is nothing subtle about today's conflicts. Best treatment for diabetic proliferative retinopathy is %74 against. Very, very good.
Congratulations.